All right. We're going to get going. We're going to start this morning with Dr. Slishman. So very excited to have him present and do his talk. So I'm going to turn it over to Dr. Slishman.
All right. Hi, everybody. So my name's Sam, and I live in San Luis Obispo, California. And just want to thank Fidel for inviting me to do this talk. We spoke about this title, Orthopedic Injuries and Shock. Fidel asked me to give this talk. I'll add some physics and some device discussion as well here. So I'm going to give you a little bit of a backstory before going deep into shock. So 20 years ago, I did my residency at University of New Mexico from 97 to 2000, and I started to develop a new traction splint. And it led me down a very long and circuitous path toward having a product on the market. That's what led me to meet Fidel last year. And I also have built a pressure wrap for bleeding control. I am the chief medical officer for Rescue Essentials. That's the company that now sells these products. And so I just want to say from the beginning that I am dripping with bias. And so what I'm going to do today is try to resist that bias to whatever extent I can. I don't have any product images in this talk. I'm not going to name any competing products. And hopefully this talk will just help you get some gems related to orthopedics, but actually it's weighted in the direction of shock more. I creative thought based. So I should say on the brochure, there is a line that says evidence-based guidelines associated with what I do. And that was I would say a typo maybe. I just noticed it recently. This talk is not an evidence-based medicine talk. There's nothing against evidence-based medicine, but this is more of a creative type of talk, and hopefully it'll keep you awake a little bit more as well. As far as finding a title, we named it Orthopedics and Shock, but another title could have been this, Slishman's Unified Theory of Human Emergencies. That's a joke. You're all on mute, so I don't know if it's a good joke. But what we'll cover today are what is shock, and this is going to be 4 different sub lectures really. What is shock? I will try to tie some physics and physiology. That may turn off some people, but it won't last too long. I'll talk about which orthopedic injuries can lead to shock, and then which ortho devices can help to limit shock. So just getting right into it here. What is shock? And when I got thinking about this talk, I did what often people do is they go to Google and we put in what is shock. This particular slide comes up quite a bit, and it's not bad. It captures what most of you have probably seen in many different forms over the years. You have hypovolemic shock, the tank is low, pump failure, Basogenic shock, and all of these things sort of lead to a common area where you have cell anoxia, cytokine release. Probably more people in the world know the word cytokines than ever before because of COVID. You get clotting and bleeding, and surely everybody here knows the look of shock too, with the brain effects of it. As you head on down, you have end organ damage. So kidneys take a hit, lungs take a hit, the GI tract. One of my beefs with this slide is that they don't have a brain there. And that's really my favorite organ, the one we work on the most. And, but in any case, this is a common presentation for shock. There are also some types of shock that aren't represented in this slide as well. And I'll try to go into those later on too. So moving forward, I'm going to go into the physics of how I think about shock. I majored in physics in college, and I remember when I got out of college, started medical school, there were so many analogies that I could see between physics, circuits, and the human body. So I thought I'd try to make some of those connections today. So Ohm's law is, everybody who does anything with circuits knows V equals IR. And V, that's your voltage. And it's your potential difference, the thing that's sort of pushing electrons down the line. If you don't love circuits, you like rivers instead, then you can think of volts as sort of the height of a waterfall. I is the intensity, so the electron flow rate. If you like rivers, then it's the rate of water going over the falls. Resistance, R, that's expressed in ohms, and that is what is slowing the electrons down. So it's your appliance, your light bulbs, iPads, TVs, and the like. For a river, it's waterfall, it's the air, the rocks, anything that slows down flow. All right, and then your next formula is Joules law. So power is volts times current. So this is expressed in watts. It's an energy delivery rate. So joules per second, calories per second. It's your energy usage for whatever your appliance is. Appliance maybe, yeah. In the case of a waterfall, it's what it feels like standing at the bottom of the falls. So if you're at the bottom of Angel's Falls, even a small trickle can hurt. And if you're at the bottom of Angel's Falls with a pile of water coming down on you, you're gonna get killed. So these are human analogies to those letters. So volts is a little bit like your blood pressure. Resistance, R, is a little bit like your systemic vascular resistance. I, your current, is like your cardiac output. And you can further subdivide cardiac output between stroke volume and heart rate. So stroke volume, every time the heart beats, how much blood gets ejected from the heart. This isn't something we talk about a whole lot, but this is what interests me the most, is the power. So, and specifically, you have a brain. So what is the energy consumption rate of a brain? Calories per second, oxygen consumption, ATP to ADP, AMP conversion rate. Basically, how fast we use oxygen and nutrients to get through the day. And when you look at a slide like this, probably you think, oh no, he's not going to do that. I'm not going to force you through all of these things, but oxygen consumption rate is related to arterial oxygen content minus the venous oxygen content. And within these is is hemoglobin, as well as your pulse oximetry, your oxygen saturation, as well as your partial pressure of oxygen. Sometimes I think people maybe confuse those two. So your pulse oximeter is measuring this. It's measuring how well your hemoglobin is holding on to oxygen. And I don't know if you've ever spent time thinking about your pulse oximeters, but it's a miraculous device. It has essentially two different wavelengths of light being flickered through the tissue. And depending on how saturated the hemoglobin is, it gives you an output of where you stand. Partial pressure of oxygen just reflects the concentration or percentage of oxygen that is getting forced into the blood. So your oxygen consumption rate is going to be this difference times your cardiac output, and you get a formula that looks like that. So again, my biggest goal is cerebral perfusion, and maybe I'm giving maybe the title of this talk is wrong. Maybe it should be not shock related, but cerebral hypoperfusion related. But either way, I am most interested in keeping the bulb lit. So one more formula page here. And I think everybody my age has to have a Homer picture in their talk. So yeah, the whole goal is keeping the bulbs lit. Using Joules Law, and back in my physics days, we used to say plug and chug a lot. So you have power is related to volts times current, and that can be replaced with I squared R. I squared being oxygen consumption rate squared times systemic vascular resistance. Plug and chug, and what you're left with is a formula that looks like this. And so what matters most? This is what matters most to me. Just stroke volume, heart rate, hemoglobin, systemic vascular resistance, oxygen saturation, and oxygen partial pressure. All right, so that is, as I said earlier, there are going to be sort of 4 different discussions today. And that is all the physics, so you don't have to worry about a whole lot more formulas. I put this in as a little bit of a break, and I think that in every talk, it's useful if you're triggered to go Googling other things later on. So if you've never seen this image or never heard of this thing, this is the Cunningham Sanitarium from 1928. There was a Dr. Cunningham who convinced a wealthy person, last name Timken, I believe, to build a hyperbaric hospital. And I feel like I don't think this would work today, but I often now in times of COVID think about this picture, because wouldn't it be useful to be able to force more oxygen into the bloodstream today? I know that there are some studies, some small case reports related to COVID where they've taken 20 people, they have put them at 2 atmospheres in hyperbaric chambers, and for 90 minutes, 5 days in a row, and there've been some good outcomes. So wouldn't it be remarkable to be able to do that on a larger scale? And that's related to that last term. So partial pressure of oxygen, if you can just chase that, maybe you could help some people, but it's not the most practical thing in the world. All right, so going through these different categories of shock, what all can dim our bulbs? And so I'm going to go through a variety of images like this. No, I've done a talk like this in a small group setting, and that's a little bit more fun because I can ask people around the room. I can say, hey, look, what's an example of hypovolemic shock? And then let's go through each of these 6 items. What's actually happening during hypovolemic shock? And also think about your treatments. What are the treatments aimed at? And going point by point. I'm going to rifle through these faster so that you don't have to suffer through it too much. But in the case of hypovolemic shock, I say trauma, postpartum GI, but at the end of the day, I'm talking about bleeding. What is the problem with too much bleeding? And really, it's this term here. So your hemoglobin, that's the snag. Stroke volume is also a problem. The heart rate compensates and speeds up. Stroke, systemic vascular resistance compensates and tries to push more blood so that it goes up to the bulb. Oxygen saturation isn't probably changed by most trauma. Partial pressure also. In terms of solutions, there are the things that you go to. So, we are giving a lot more blood nowadays, but what you will often do first is give saline, and that impacts your stroke volume more than probably anything else. And you're going to give oxygen because you have it, might not give it, and it's probably going to help. Nobody's going to fault you for giving oxygen, and you might be actually helping people. So that's one category of hypovolemic shock. Another one, slightly different, but still hypovolemic shock, is this here. So bleeding is not the issue. You're not running out of blood, but stroke volume is. And so these people need more volume. They need saline or lactated ringers. What they might need more than anything else is for you to raise their legs in the air and get some more cerebral perfusion. You can give them oxygen as well. Probably get them out of the sun. And then another category, hypovolemic shock, is basically all of these. So low intake, vomiting, diarrhea, diuresis, burns. Burns are horrendous when it comes to having a low tank. I remember doing burn rotations during my residency and just being amazed by how much fluid these patients would require. And really just trying to keep that stroke volume up so that the brain stays perfused. All right, so leaving hypovolemic shock, moving on to cardiogenic shock. Probably the best example is MI. In this case, problem isn't here or here, here, here. It's really both the stroke volume as well as the heart rate. And the things that we try to do to help people with heart attacks are, well, you'll give nitrates, and that is aimed at the systemic vascular resistance, but it's also aimed at dilating the coronary arteries. So getting more blood flow to the cardiac myocytes. You may give morphine as well. That's aimed at just flogging the heart less and taking some of the weight off of it. And you're going to give oxygen to some extent to be able to get that failing heart to pump proper blood and oxygen up to the brain. In case of atrial flutter, atrial fibrillation, myocarditis, I don't know if it's obvious. I have a little more of a mechanical type of brain, and so I think of, when I see this problem, I actually think of pumps. I think of water pumps, and if you've ever primed a pump before, if you have any air in the pump, it's called cavitation. When I see atrial flutter, atrial fibrillation, you have a pump that's just not getting the blood out. And so we will do things that will aim at improving the stroke volume, improving the heart rate. When you give diltiazem in the case of AFib with RVR, what you're trying to do is give it a little more time to fill up with each pump. And of course, you can give oxygen. You can give to improve the saturation and partial pressure. Now, tamponade, this is in one of the talks yesterday, I forget the name of the speaker, but this is labeled as an obstructive cause of shock. And I think that's fine. These are all words, but at the end of the day, how do you make somebody feel better? So, in the case of tamponade, you have blood surrounding the heart and it's stopping it from fully expanding. So you're not getting enough blood flow out of the heart. Your stroke volume is impeded. And the solution in this case is to get that blood out of the pericardium. And this may not be the best picture of tamponade. There's a hemothorax there as well. Tension pneumothorax is an obstructive problem as well, but it's a cardiogenic shock too, because all of that air on the one side is pushing the heart and restricting proper opening. In addition, it's affecting the oxygen saturation, oxygen partial pressure, and you want to get the air out. I have to say, I got this slide from Canva, and it seems like this chest tube isn't doing a good job, but thought I'd use it anyway. Another example of cardiogenic shock is drug-induced. So, propranolol, diltiazem, these are medications that will, if taken to excess, will impede your stroke volume or heart rate. If you take too much, they may affect your systemic vascular resistance too. But the treatment for these is to do a little bypass using some glucagon, calcium in the case of diltiazem. And I'll go to the next here. So that's the end of the cardiogenic shock category. Basogenic shock, all of these are related to this term here, the systemic vascular resistance. And for these patients, they need fluids, and more fluids. For whatever reason, I remember things during my residency more than anything in the last 20 years, but I remember my first patient with real sepsis, and it was just astounding how much fluid they needed to just get their heart rate to be a little bit slower and to keep their blood pressure up. In the case of anaphylaxis, this is a problem with systemic vascular resistance too. It can also be a problem with oxygenation as the lungs and the throat close off. I have not been saying a whole lot about pressors, and probably you know, an intensivist would be spending a lot more time on that, but I thought I'd just throw in perspectives on pressors with this slide here. So, you know, we get, there we go, back. We give, you know, there's dopamine. That was far more popular when I did my residency, and shortly after that, I remember giving dobutamine to a patient with hantavirus and getting high fives and thumbs up when she survived. Nowadays, Levophed, norepinephrine, is much more preferred. It seems like it has maybe some, keeps people alive longer. But you're aiming at the systemic vascular resistance with norepinephrine in particular. The reason we keep using epinephrine in the case of anaphylaxis is because you have a little bit more bronchodilatory effects with epi. And then there is vasopress or vasopressin. And true confession, never in my life, I've never used it once. I've never seen an intensivist use it once. And so maybe that is an implication on, you know, the blessed medical life that I've had. But vasopress is aimed entirely at this, your systemic vascular resistance. Maybe someday I'll use it. All right, moving to the next here. Another basogenic shock example is neurogenic. So anybody that has a spinal cord injury above roughly T6, that's something to consider. So they can knock out their sympathetic tone and have purely unopposed parasympathetic tone. And what happens is you wind up having a basogenic shock. Systemic vascular resistance drops, give these patients fluids. There's another example. So you can give, you know, probably most people here have bottomed somebody out with nitroglycerin. I'm just guessing, but this is a remarkably fast blood pressure dropper. So we give fluids to counteract that if it goes too far. Luckily, it fades away quickly. Nifedipine, I haven't seen or used nifedipine in ages, but that is more of a systemic vascular resistance calcium channel blocker than diltiazem, verapamil. All right, I'm going to spend more time on this slide because this is the closest I've ever been to shock myself. That's a picture of yours truly. It turns out, I suffer from, I get angioedema when I am cold. So back in 2002, this was first discovered, and it was on this day. So I was swimming, I was snorkeling with a friend in Monterey Bay. It was really cold. And I came out and my face was just puffed up. And I thought, man, maybe my wetsuit is just too tight. And ever since then, I have had progressively worse histamine reaction when I get in the cold. So it's very predictable. Now I get in the cold water, I first develop a headache, then I get some itching. And eventually, whatever part of me is exposed to the cold water, it just swells up. So my hands, my face, my legs, and they'll be bright red. And what's happening is I'm vasodilating. And the worst example of this that I ever experienced was about 2013 or so. I had just met my wife, my former girlfriend, and we went to Lake Tahoe for a river trip. We went camping. I went down to the water to just jump in. It looked beautiful. It was super cold. I hadn't eaten. I hadn't anything to drink, and but I was enjoying it. I was enjoying swimming, and I got out and I started to walk up the hill toward the campsite, and I can remember basically just the room closing in on me. I couldn't lift my head off of the bench. Things started to, my face started to swell. My legs were swelling. I remember this is the closest that I've ever been to experiencing shock myself. And what I recall from it was, my three remaining neurons were all being channeled to my stomach and my anus saying, please don't vomit or have diarrhea in front of my wife. And so luckily, none of that happened. She covered me up and I eventually went through a shivering phase and then was okay again. But the combination of angioedema, prolonged submersion, I should say, is something, I mean, when you're in the water, you have hydrostatic pressure pushing on your body, and that's forcing fluid into your kidneys. They think there's a higher blood pressure, so that's why you have to pee in the water. Prolonged submersion will cause, your tanks get low then too. Then if you have rapid rewarming and then you take somebody's wetsuit off, that is a remarkable cocktail for getting vasogenic shock. Put on top of that a trauma or a shark bite, and these people do poorly quickly. So long story short, if you find me in the water looking like this, but lying flat and not speaking well, put in an IV, give me some fluids, leave the wetsuit on for a little bit longer, and warm me up gradually, please. All right, so I am going to say a few things contrary to that first slide that I put on. So obstructive shock, for electricians, I call this short circuit shock. For plumbers, I call it plugged pipe shock. These terms really aren't as relevant when it comes to obstructive causes of shock. And that's because you just have to get to the problem. So in the case of a stroke, there is a clot that's in the brain that's stopping perfusion. In the case of epidural hemorrhage, there is a larger clot that has to get sucked out. Cerebral edema, high altitude cerebral edema, you want to get these people to a lower altitude to be able to get some better perfusion to whatever extent you can. Arterial gas embolism, I've never seen it. I wonder if anybody in the room has seen it. It's something where when you are diving, you get to the top, bubbles get into the brain quickly, and death happens fairly fast. If you do have somebody you suspect arterial gas embolism and they're still alive, that's somebody that's a candidate for a hyperbaric chamber, but not too frequent, probably in Grand Junction, I would imagine. All right, so just moving down from the brain, if you have carotid pathology, a hanging, there's a different type of shock, a different type of obstructive shock. And in both of these cases, you have to get to the problem. You can give oxygen, you can work on all of these things, but at the end of the day, you have to relieve the obstruction. Pulmonary embolism is in a similar category. You can give oxygen, you can do all of these things, but trying to get that pulmonary embolus out is the target. Now, this is it's slightly a joke, but also something to think about. When I was putting this together, I thought, what exactly is it? Cerebral hyperperfusion I'm talking about? Is it stroke or is it shock? What is, orthostatic hypotension? What's happening there? So patients, when they stand up quickly, the blood leaves their brain. Oftentimes they pass out, and it turns out that passing out is somewhat of the treatment. You are lying down and blood gets back into the brain, and then they wake up again. If you're stuck in a centrifuge, that came to my mind when I was thinking about this. If you're stuck in a centrifuge, you basically have prolonged orthostatic hypotension. And when I Googled it, this image comes up. This is from Spies Like Us. I never saw the movie, but maybe other people my age in the room will have seen it. And the treatment is to turn off the centrifuge. But I call it a pseudo. What do you want to call it? Is it pseudo obstructive, hypovolemic, vasogenic? Not really sure. But yeah. And this is a whole nother category of shock that isn't captured in that first slide. So, if I'm running a 220 appliance on 110, or if I have tainted fuel in the tank, you get shock. The brain is not getting what it needs. The bulb goes dim. And these are all examples of it: carbon monoxide, cyanide, methemoglobinemia. Hypoxemia is the most obvious, probably. And you really just have to treat that problem. You know, all of these things, you give as much oxygen as you want. If you can get them into a hyperbaric chamber, that's great too. But you got to solve the underlying problem. All right, so at last, I know that people may have come onto this talk thinking orthopedics, I love orthopedics, and that took a while to get here. But these next few slides will be more ortho focused. So in the case of a crushed pelvis, and yesterday, Dr. Alfonso did a great job talking about pelvic ring fractures. So I'm not gonna dig into the anatomy as much. I did learn something yesterday from his talk, and that was the bit about pulling the toes together and that having perhaps as much effect as the pelvic binder. I'd never seen that slide before. I thought that was great. But the big problem, big category of shock when it comes to a crushed pelvis is hypovolemia. These people there's a lot of vasculature in the pelvis, and when it gets crushed, those vessels pour blood into an area that is hard to apply direct pressure. It's hard to stop bleeding within the pelvis or the peritoneum. And so the treatment really is you're going to use saline and blood if you can, but the pelvic binder is critical for these folks. And what he said, I just want to reiterate, having a high pelvic binder, no good. So you want it to be down around the greater trochanters as well. And I would say, you know, I also want to say, as far as all of the orthopedic injuries that you can have, this is probably the most immediately life-threatening in terms of bleeding. You know, a scapular fracture, I include this, but for a different reason. So scapular fracture, people aren't bleeding to death because of scapula marrow pouring blood out. But when I see a scapular fracture, I'm thinking of all of the other things that may have come with it. So it takes a lot of energy to break a scapula. And so if I have a patient with this particular x-ray, I'm probably going to do a CT and not so much looking at the, well, it would be nice to see what the scapula looks like too. But I am wanting to know, is there a pneumothorax, a hemothorax? Is there tamponade? And also that same logic applies to anybody with a first rib fracture too. If you have either of those types of injuries, that's a high energy problem. And so you want to be looking for other problems as well. On the topic, I'll just do the entire spine right now. So, you know, if you have a high spine injury above, say, 2, 3, 4, 5, then the issue is breathing. As you move on down the spine, mid-spine, we're worried more about, as I said earlier, the basogenic causes of shock. So if you have if you take out the sympathetics, then you get a basogenic shock. Lower down, if I see somebody with an L-spine fracture after a car accident, then I think, you know, has there been excessive hyperflexion, and is there an associated abdominal injury? So are they going to have hypovolemic shock by way of, you know, bleeding into the peritoneum? So in all of these cases, stabilizing and transporting is probably the best we can do from pre-hospital standpoint. And moving to another cause of shock. So one thing I realized when I picked this slide, I thought, you know, I don't want it to be too gory. And then I sat through Dr. Alfonso's lecture yesterday. I thought, you know, these people can take it. In any case, open fractures, the issue is not so much in the pre-hospital realm. I mean, you're not going to be seeing septic shock from open fractures in the pre-hospital realm. But that is the downstream problem. It's causing sepsis. The things you can do are what Dr. Alfonso mentioned. You can try to clean it to whatever extent you can with the time that you have. I will say one thing about, I'll go into traction just a little bit. You know, if you have bone that's sticking out and it's soaking with mud, probably not the best to apply traction and pull that mud back in. But if you're able to clean the area to some extent before setting these things, I think that's a useful step. Fat embolism is another thing that's related to orthopedics and shock. So if you have somebody that has tire tracks over both of their thighs, and you basically are transporting them in, and then all of a sudden they start desatting, their blood pressure is dropping, then you may want to be thinking about a fat embolism. Another true confession, I have never been the person to diagnose a fat embolism. I know that it exists, and maybe someday that will be something I will diagnose, but I think more often it gets diagnosed downstream after they get through the trauma room. Okay, so my favorite, I was going to say my favorite, but this is the fracture that I have spent the last 20 years thinking about. Dr. Alfonso covered it quite a bit yesterday, so I don't want to bore you with it too much, but femur fracture it's an interesting animal because it's life-threatening, unbelievably painful, and it's incredibly debilitating. So when people have these injuries, their first step is very often to be auto splinting. They'll grab their leg and they try to traction their own legs. Actually, there's one other feature of femur fractures that I think is interesting, is that patients are often very conscious. I mean, if you have these multi-system, bone fracture MVCs, then that's a different animal. But comparing femur fractures with pelvis fractures, people with crushed pelvises, they're often unconscious. They have a lot more going on. Isolated broken femur is someone who's talking to you and they are just hemorrhaging within this thigh, and they're miserable. And they can bleed to death without having a laceration. So if you've ever seen a person with a femur fracture that's not been splinted to any extent, I mean, the thighs can just become enormous. They go from being, essentially cylinders or cones, maybe that's a better term, cone, to being spheres. And that's the reason that two different reasons to apply a traction splint. So number one, and most compelling, is to limit pain, but also we're just trying to turn that sphere into maybe more of a cone or cylinder to give some external pressure and try to get a little bit less bleeding into the thigh. And of course, these are folks that you're going to put in your IV and give saline and blood as well. And nobody's going to fault you if you give them a little bit of oxygen. As I said in the beginning, in terms of bias, I can spend a lot of time talking about traction splints. I'm not going to, you can ask me any questions that you want at the end of this, but I don't want to go too far into that right now. So those are three of the four categories I talked about from those first couple of slides. The last bit is going to be about devices and just comparing them and thinking them through. Putting this talk together was useful for me too, because it led me to put together this last slide. And feel free to, if you want to take a screenshot of it, I think it's an educational tool for others, maybe for your students. But get rid of the numbers. And the educational step here is to go through each of these devices and just think about these different categories with each of these products, each of these categories of device. So, in the case of a pelvic binder, I think this is incredibly life-saving. It can be a super helpful thing for somebody who is super sick, but the likelihood to be used is surprisingly low for a variety of reasons. Patients who have crushed pelvis, they have a lot of other things going on too. Sometimes they're unconscious, maybe chest trauma as well. Maybe they have broken femurs. And it's not the easiest diagnosis to make. So broken femur is often pretty obvious. The leg is just going the wrong direction. But a crushed pelvis isn't always obvious. Not only that, right now we are less inclined to rock on the hips for fear of making them worse. So my only message regarding pelvic binders, my additional message would be, if you suspect it, if you're concerned about it, put it on and move on to the next thing. They don't cost a ton. They don't take a lot of space. They don't take terribly long to apply, but they do have some training required. You know, in terms of pain reduction, that's not really the goal of the pelvic binder. Maybe you'll get a little bit of pain reduction, but in terms of risk, there's really not much risk with applying them. A traction splint is a different animal. So you have, I think it is life-saving if bleeding into the thigh is the underlying problem, or if that is a fear. Likelihood to be used, I think it's a little bit higher likelihood because we have more isolated femur fractures. Doesn't take terribly long to apply it. That is product dependent. A little bit pricier than the pelvic binder. But pain reduction is just, it's incredible. When you put a traction splint on somebody who has a broken femur, you know, you titrate to, you know, that's your goal. And the risk of putting a traction splint is quite low, really. It's prolonged care with a traction splint that might be more risky. Maybe you develop some pressure points. But I think that if you have somebody you suspect they have a femur fracture, you can put it on and feel comfortable. Shoulder sling, man, you know, life-saving, probably not, but likelihood to be used, absolutely. Costs virtually nothing, and pain reduction is huge. So if somebody has pain anywhere from here to here, put them in a shoulder sling and call it good. And that really applies to a splint as well. So maybe takes a little bit longer to put it on. So that might make you less likely to use it. But man, you put a splint on somebody with a broken limb and they'll say thanks. You know, anybody who's done this for the past 20 years has seen a sea change in terms of how we think about C-collars and backboards. Back in my emergency medicine residency, my mentor at the time, Mark Hoswell, did a study comparing people. He went and did a sabbatical in Malaysia. And he did a comparison study with Malaysian system, where it's basically scoop and run versus use of the C-collar. And he found that really there wasn't that much difference in terms of benefit to putting these on. However, we are very likely to use them still for fear of all kinds of things. Making the problem worse, having lawyers chase us, and you know, you just don't want to miss or make somebody a paraplegic or quadriplegic. So this is, you know, we'll continue to use them for a long time, I think. Doesn't take too long to apply. There is some level of training required. You want to get it sized right. You don't want it to be up around the ears. There is pain reduction too, to some extent, but if you put them on wrong, then it can hurt more too. Backboards is, that's a story in and of itself, but you know, in terms of life-saving, I give it a 3 in terms of life-saving, but that's largely because it just gets patients moved faster. Patients on backboards, however, are miserable. It's a painful experience. And so when they come to the ER, I make people on backboards to be, you know, they are my highest priority just in terms of getting them off. Pretty high likelihood to be used still. They take a while to put on though, so they do delay a little bit of the transport, and that adds to the level of risk. I'll group these 3 together: wraps, tourniquets, junctional tourniquets. You know, and this is an area where I have a lot of bias too. I'll just say that once again. You know, a wrap to me is something that, regardless of what the design or type is, it's intuitive. So somebody's bleeding, your first instinct is to put pressure on the spot that's bleeding and then wrap it and hold that pressure until bleeding stops. You don't need to have a training session to indicate, you know, how to do that. I had a patient recently, you know, she's on dialysis, her clot blew, and her son took a shirt and then another shirt, and it was wrap, and that was what stopped the bleeding. So, you know, a wrap, cheap, you know, doesn't take a lot of space. It can be life-saving, is very likely to be used. Doesn't take a ton of training. Pain reduction, it actually can reduce some pain too. just by covering those exposed nerves. And the risk of using a wrap is really quite low. Tourniquet, on the other hand, and I should say, I include wrap tourniquet, junctional tourniquet here with orthopedics. I think orthopedists, they love bones, but bleeding control is still within their wheelhouse. So as far as a tourniquet goes, absolutely life-saving, and it's interesting to see how much more we talk about tourniquets now than we did 20 years ago. Pretty likely to be used, but I give it a 3 because they are not likely to be near the injured party. And to some extent, that's because of expense. So a tourniquet, best tourniquets today cost $30 to $40. So the higher the price, the less likely they are to be near injuries. And there is some level of risk when you put a tourniquet on. You're risking destroying tissue as well. And yet in yesterday's talk, one of the talks, there was mention about loosening the tourniquet while transporting. And I thought that was interesting. Most people that I've heard, and I'm not saying that's wrong either. In fact, I would like to see more of that kind of thinking, where you actually you keep reevaluating the patient, seeing has the bleeding stopped, This mantra of once you apply a tourniquet, it has to stay on until you get to the emergency department has always bothered me, to some extent. So, by maintaining a tourniquet on for a long time, there is definitely risk, and that risk goes up over time. And if anybody really pays attention to like tech medical world, there's the category of junctional tourniquets, and this is for types of bleeding that happen higher up in the thigh or even toward the abdomen. I remember a patient, not of mine, but a story. I lived in Jackson Hole for a short time, and there was a person who got skewered by their own ski pole, and they just bled to death, and it was up in their high thigh. A tourniquet would not have worked. And so when I think of junctional tourniquets, if you're wearing a junctional tourniquet, then it has great potential to be life-saving, but likelihood to be used is very low because they're pretty pricey. The people who are using, they're in the military settings. There's definitely a good amount of training required, and it's for a pretty small sliver of medical problems that it's addressing. So that is my take on junctional tourniquets. If you want to spend the money, if you want to wear it, if you want to have it near you all the time, then great. And I thought I'd end off with mask trousers just because it has all of it. Military anti-shock trouser. When I trained, these were just going out of fashion, but I remember a couple patients coming in with them on. This is another example of if you're wearing it while you're driving the car, maybe it'll be helpful for you. The car that crashes, But it takes, they're bulky, they're expensive, they take a lot of training to put on. They also cover a good number of injuries. So the goal of a mask trousers is you're trying to auto transfuse. So you're squeezing the legs. There's actually an abdominal compartment too. So you're squeezing all of these compartments and trying to shove blood higher up toward the head. And they're just not that, they may be effective if you're wearing it at the time of the injury, but otherwise pretty hard to implement. So we don't really see mask trousers in use to any extent anymore. And so, those are the main devices that I think are relevant in the sort of pre-hospital orthopedics world. Feel free to call me or email anytime if you have other things that you'd like to talk about.
All right, very good. Thank you, Dr. Slishman. That was awesome. Appreciate it.